Yes, we can hear you, see you, and see your slides.
Lovely. We'll make a start then because it's after 4. A couple of technical issues, but I think we've figured it out. But please do bear with us as we go through. So, welcome to Medical Needs in School Suffolk. Today's workshop is on epilepsy, and our presenter is Dr. Carmony Moodley. Dr. Carmony Moodley is a paediatric consultant working at Ipswich Hospital. She's practiced here for 4 years. Prior to this, she worked at West Suffolk Hospital and across Suffolk in paediatric services. She has specialised in paediatric neurology and has a special interest in epilepsy. So, Dr. Carmony Moodley, welcome. We're going to swap seats now. So over to you.
Take off my mom. Okay, hello everybody. I don't think I can see many of you, but and thanks for Kate's introduction. So I will just be talking to you about epilepsy and an introduction into this quite complicated topic, just to give you a basic understanding of the things that you might come across in schools and how to deal with them and troubleshoot. Can you still see the screen, the slides?
We can see the front slide.
Okay.
If you use your arrow keys, you should be able to change to the next slide.
Yeah.
There we go.
So I thought we'll start off with a definition of what epilepsy is. And you might all know that it's a condition that affects the brain. And when somebody does have epilepsy, it basically means that there's this potential that seizures can be recurrent or they can have more. So anyone can have just a one-off seizure, but that does not always mean that they have epilepsy. Epilepsy is generally diagnosed if a doctor thinks that there's a high chance that that can be recurrent. And we make that decision based on the investigations that we do and the history that we take from the families. Interestingly, epilepsy can start at any age, and there are different types of epilepsy. So some are more straightforward than others, and some are definitely more complicated and involve, more intensive treatments and things like that. As I said, some children can outgrow their epilepsy, but for a small portion of children, it is a lifelong condition, and therefore it's important, to do the appropriate psychology that goes with the diagnosis of epilepsy. So what are seizures exactly? So in our brain, there is electrical activity going on all the time because the cells in the brain are sending messages to each other. And they do this by basically traveling through electrical activity in the brain. Now, a seizure happens when there's a sudden burst of intense electrical activity in the brain. And what this causes is that it causes a temporary disruption in the way the brain normally works. And in some cases, the messages don't go to the right part of the brain, and therefore the child is not able to execute a function, perhaps, that part of the brain is involved in controlling, and it results in an epileptic seizure. So as I mentioned in the beginning, there are different types of seizures, and what happens to someone during a seizure partly depends on which part of the brain is affected by the abnormal electricity. So during some types of seizures, which you probably all are aware of, there's often collapse to the floor and generalized jerking, which can be quite scary. They can also be tongue biting and wetting. But the more subtle ones, which are often overlooked, are the ones that we perhaps need to pay a little bit more attention to and be a little bit more vigilant to, especially in classrooms. And in these sorts of seizures, the child often remains alert. They might be aware of what's going on around them, but equally that they might not be aware, and it might be recognized by teachers as a lapse in their concentration, or they're just not paying attention, daydreaming. So it's important to, not to be dismissive of those sorts of episodes that happen in the classroom, especially if they become recurrent and especially if there are other issues around learning with that particular child. So sometimes they may have an aura, so basically an abnormal sensation that comes before the abnormal movement or the actual seizure. And this is often described as a funny feeling in the tummy, or some children might have visual auras, or they might actually take themselves to a quiet place and sit themselves because they have this impending sense that something is going to happen. So sometimes there is unusual sensations. And as I said, in the more common ones is when they actually collapse to the floor, they're stiffening and then jerking. And that's easy to recognize, but it's the more subtle ones that are a bit trickier. So how common is epilepsy? So of all the serious neurological conditions, epilepsy is actually very common. And we often use this when we diagnose children because sometimes they don't realize how common it is, and it helps in, again, the psychology around the diagnosis. So it does affect around 600,000 people in the UK, and it basically means that 1 in every 100 people in the UK will have a diagnosis of epilepsy. So around 87 people are diagnosed roughly every day with epilepsy. How is epilepsy diagnosed? So unfortunately, epilepsy is not easily diagnosed because we don't have a specific test that tells us one way or the other that this child has epilepsy. Like with diabetes, we can do a blood sugar and the results tell us, well, it's diabetes or not. So the main way that the doctors diagnose epilepsy is by actually taking a very detailed description of the seizures. Because over time, we are able to basically look at the semiology of the actual seizure, so what actually happens to the child, to try and map it to the area of the brain that controls that function and where the potential problem might be. We do have a few tests in our armor that we can use to help us come to that conclusion. And one of it is a brainwave test known as an EEG, which basically looks at the electrical activity in the brain. But again, this often depends on the child having an event at the time when the investigation is done. So sometimes it's not always helpful, and equally a normal test doesn't exclude epilepsy, especially if there's a very high clinical suspicion based on the history. I mean, we also have scans. Scans are quite good for telling us structurally if there's anything that predisposes to seizures, but obviously doesn't tell us information about electrical activity and all the subclinical things that can go on with all the complex functions of the brain. So moving on, how do we treat epilepsy? So the main treatment for epilepsy is actually medication. So we have medications called anti-epileptic drugs. And again, the medicines don't actually cure the epilepsy, but what they do is that they help to reduce or stop the number of seizures. Now, I think from your point of view, it's important to realize that the prolonged seizures, so the seizures that last for more than 5 minutes, there's a danger of starvation of oxygen to the brain. And those are the seizures that are particularly dangerous to the child in terms of impacting future learning, future cognitive ability. So it's important to get prolonged seizures under control. Usually when we see children, we often come to an agreement in terms of goals. So we aim initially for 50% reduction of seizures, and obviously a bit better if the medicines actually work effectively. But it might not take away all the seizures, but we aim for a reasonable reduction and also for the prolonged ones to be halted. So many people find that their seizures stop with first or second medicine. So again, it is a bit of trial and error. We use the brainwave test to try and work out what is the best treatment based on previous research and things like that. So we know that for focal seizures, so seizures coming from one part of the brain, a particular group of medications work, but seizures that come from all parts of the brain, other medicines work. So it's important to try and, kind of make a syndromic diagnosis because that helps with our treatment choices. If we are lucky, the seizures are controlled on one medicine, but sometimes it's not unusual for seizures to be a little bit resistant and we need to go on to a second and a third agent. Now, just as much as the seizures affect cognition, learning ability, it's important, I think, from your perspective as well, to realize that the medication itself, the side effects associated with epilepsy drugs, also impact on cognition, learning, attention, and things like that. So as clinicians, it's important for us to be aware of problems in the classroom, particularly with learning, especially when we've started a new medication, because it could be related to the side effect. And obviously, in our treatment of epilepsy, it's always a balance. So we want to do more good than harm. So if the side effects are worse than the actual reduction in the seizures, then it might prompt us to make a change in the medication. So it's important to have that feedback through parents, obviously, about whether it's affecting their learning and things like that. If a medicine works well, then if the drugs don't work well, so often if we are on 2 or 3 drugs and we're still not getting the seizures, then there are other options. And the other options do include brain surgery, which is quite complicated, and I think beyond the scope of this talk. But also there's other types of treatments, which is called a vagus nerve stimulator. It's like a pacemaker that's just put underneath the neck, and that helps to regulate the impulses of electricity to the brain and in some way helps to control the seizures. It might be relevant to you because you might have children in your classroom with these devices in place. So it's just important to know that why they're being used. And sometimes we use a special diet called a ketogenic diet, which is essentially a very high fat, low carbohydrate diet. And that just helps with metabolizing energy differently in the brain, and in some way that helps to control seizures and can be quite successful. It is important to know because obviously with school dinners and things like that, we need to be quite strict with this diet. I think more relevant to schools is probably how you can help support somebody when they are having a seizure. And I've just put in a little bit of do's and don'ts. I don't think you can do anything to actually stop the seizure, but you can actually prevent further injury to the child. I think important is to recognize that they are having a seizure and then putting the first aid in place. So often what we do is we want to protect them from any further injury. So try and clear out the area, remove harmful objects from nearby, and try and basically, limit the amount of people that are around the child. We tend to advise cushioning the head. As I said, you can't stop it, but you just need to reassure the child that they will be okay, that help is on the way. Sometimes children with epilepsy, they often have an identity card, and sometimes on the card, there might be plans as to what medications to administer, when to administer. I know our epilepsy nurse specialists work hard in going into the schools to make sure that there's up-to-date care plans, so that you are all aware of what to do in the event that something happens. But in case that child didn't get a plan, it's important to just be aware that there might be some clues in terms of a bracelet and things like that. It's important for us for you to time how long the event is, because as I said, it's the prolonged ones that we actually really want to know about and also want to reduce with our treatment. So timing it and videoing it. I'm not sure whether you're allowed to actually video in schools, but I guess with parental consent, we often ask parents to ask schools to video events, because sometimes, as I said, when the diagnosis is not clear, based on the investigations we've done, videos are quite helpful and give us a lot of information. But I understand all the governance that goes around videos, so obviously that needs to be done with consent and things like that. Again, aid breathing, in the sense, put the child in the recovery position and ensure that, once the jerking is stopped, that the child is not vomiting and cannot choke on their secretions, and then call for help. Stay with them until they're fully recovered. Always be calm and reassuring, but just remember that if they're more than 5 minutes, you probably need to get an ambulance to get to you. What we don't want you to do is restrain their movements, because you can't stop the seizure. Don't put anything in their mouth and prevent them from clenching, because you can cause harm to yourself. And don't try and move them unless they're in danger. You have to let the seizure pass. Don't give them anything to eat or drink, because they are probably not in full control of their swallow. and you can cause more harm. And don't try and stop the seizure and bring them around, because obviously you just need to let it pass. You need to call an ambulance if you know that it's their first seizure. So if they're not known to medical, doctors, if the jerking continues for more than 5 minutes, if they've had one tonic-clonic seizure after another, so if they've had clusters of seizures with no regaining of consciousness between, and if they are injured, because sometimes if a child has a seizure, they can also fall, bang the head, and sometimes it's the head injury that needs treatment initiated. So if there's an injury inflicted, then they need to be seen by a doctor. Or if you believe that they need urgent medical attention, I think nobody would be upset that you've called an ambulance and they are turned away than not calling one when you really do need help. I just thought it might be useful to show some videos of some subtle seizures, some a little bit more obvious, but some subtle ones, just to make you a bit aware of what to look out for. So often, I'll let it play and then we can talk it through. Tell me if you cannot see the video, and then we'll try and troubleshoot. So I'll just stop the video there, but basically I wanted you to get an idea that the child was playing, so engaging with father, and then there was a sudden behavioral arrest. I'm not sure whether you noticed that, and there was a very subtle myoclonic jerk. Sometimes you might just miss that for normal movement, or if they just a bit distracted, but that was the sudden movement was the first clue. And then the second part was obviously the eyelid flickering, and then eventually it was slap with jerking, which was more obvious. So sometimes it's a little bit important to recognize the initial bits of the seizure. But again, the parents were quite worried, but they did the right things. They reassured him, they put him in the recovery position, and they were timing it. And they did a good video for us. And they were realizing that they needed to call an ambulance and that the child needed to come to ED because it was going on for 14 minutes or so. But that's what, what we would say, that this is a generalized seizure, but had a focal onset. So it started off in one part of the brain, but then it spread to the rest of the brain quite quickly. There's just another video, the last video, and then just have a look at this and then we can talk through this one as well. So again, with this one, there's no obvious jerking or stiffening, but you notice that while he was playing, engaging, again, there was sudden behavioral arrest. He became a little bit off balance, and then there was definitely eye deviation and head deviation to a particular side. And during that, he was just less responsive. It's important to say that sometimes seizures are triggered by periods, extremes of emotion. So either if you're very excited or, if you're feeling very low. So sometimes just prior to birthdays, Christmas, some children get a flurry of seizures. So it's important knowing triggers as well to prevent them from happening. Or sometimes when they have lots of stress, which can come from schoolwork and things like that, or very late nights, then that can also trigger the seizure. So it's just important to always tell children with epilepsy to try and avoid triggers if they can. I mean, resources, a good resource for children as well as for teaching staff, I would say, is Epilepsy Action. There's lots and lots of e-learning modules that you can complete, and they're not tedious, they're very, very short, and they have lots of videos, lots of information about seizures that affect different age groups, so the younger children, right to the adolescents, and also the issues that pertain to them at the various stages of their learning and how the epilepsy impacts. So I would strongly recommend looking at the website or even directing scholars and learners to the website just for information. Yeah, well, I think that's it. If there's any questions, maybe go back to I don't know whether anybody has any questions, or I'll stop sharing. Is that okay? Does anybody have any questions?
No, thank you. That was really informative.
No? I hope it wasn't too complicated or I've not confused you.
No, not at all. I think it's worth just letting everybody know that the recording of this workshop, along with your slides, will be available for people to view on the Radwell Trust website. I'll send out a link to everybody after the workshop's finished. And if you do have any questions, if you go away and think of some questions, you can either contact me or Kate, and we can pass them on to Dr. Moodley for her to send over answers.
And the videos shared, the parents were happy to use in learning, so they will probably be happy for you to use it. Thank you. All right, I'll leave you back to Kate then.
Okay.
I'll stay there.
Okay, well, thank you very much, Dr. Moodley. If you'd have seen what I've just had to pull Dr. Moodley out from her office, and she had a whole queue of people. She's a very busy lady, and she's really, thank you so much for sharing your knowledge with us today. We really appreciate it. So if there are any questions, please do get in touch. Obviously, you know where we are at Medical Needs in Schools. We're going to have a break from our workshops now. Obviously, we're coming to the end of the term. Our next workshop is going to be in September, on the 13th of September. So do look out for that. It will be on how to write a good individual healthcare plan. And the presenter will be our colleague, Dr. Helen Griffiths, who is a clinical psychologist, consultant clinical psychologist, who will present on this very informative topic, and we hope that it will be useful around the beginning of September, perhaps when you and your schools will be reviewing your IHPs. So we're hoping that it will be nice and timely for you. Many thanks for joining us this afternoon, and we wish you a good break. We know that it's a few more weeks yet to go through for the school term, but in terms of medical needs in schools, please do get in touch if you need to. And yes, we will see you in September with another full programme. Many thanks, everyone.
Thank you.